We're going to talk about the thalassemias. So as I mentioned in my last video on sickle cell disease, there are numerous hemoglobinopathies, and the most common ones you'll encounter on your boards and wards are sickle cell disease, beta thalassemia, and alpha thalassemia. And there are different subtypes of all of these. And as we saw before in the last video, if you look at normal hemoglobin, you have two subunits of the beta globins and two subunits of the alpha globins. And the beta globin gene is encoded by one gene from each parent on chromosome 11, and the alpha globin gene is encoded by two genes per parent on chromosome 16. Let's start off with a question for this video. We have a 30-year-old female that's coming in with menorrhagia and is evaluated for anemia that has been previously diagnosed by evaluation for fatigue. She reports no shortness of breath, dizziness, or chest pain. Her family history is remarkable for anemia in her mother. Her only medication is an iron supplement. On exam, she appears well with no lymphadenopathy or organomegaly, and her vitals are normal. These are her labs here, so it shows that she has some pretty significant anemia, hemoglobin of 8.5. Her MCV is low at 68. Her platelets are normal. Her tick count is 6, so it's elevated. Her ferritin is elevated at 450, and her iron studies are normal. Her LDH is mildly elevated at 300, and her bilirubin is also a bit elevated. She has a hemoglobin electrophoresis here that shows that her hemoglobin A is actually slightly decreased. Her hemoglobin A2 is increased. Her F is also increased, and her S is 0. You get a blood film and you see numerous target cells all over. So in combining these things, you have a patient that has anemia that's not less than 7, but it's pretty profound. She's not transfusion dependent, but she has a pretty significant anemia. She also has normal iron studies and a low MCV, a very low MCV, and her hemoglobin electrophoresis shows that she has elevated hemoglobin A2, which is not normally elevated in a patient without a hemoglobinopathy. And the blood film is abnormal. So most likely diagnosis here is going to be a beta thalassemia. And specifically, it's most likely a beta thalassemia intermedia. And so the way you kind of differentiate these is by level of severity. So beta thalassemia minor is the least severe form of beta thalassemia, and that is usually going to be give you a mild anemia, so maybe like a hemoglobin of 10 or 11, and really no symptoms. They're usually not going to need any transfusions, but they will have a low MCV, which often can be confused for iron deficiency anemia. And then patients with intermedia, which is the severity is in between minor and major, they're not transfusion dependent, but they do have anemia that's usually between 7 and 10, and they can have some mild manifestations that are similar to major, and so they can have iron overload due to the downregulation of hepcidin in all of these patients due to hypoxia and a number of reasons. They can have splenomegaly, and they can have extramedullary hematopoiesis, so you can see bone expansion and bone deformities, and sometimes in some of these patients. And in major, the most severe form is that where you see all of these manifestations to the highest degree, and these patients often need to be managed with transfusion because their hemoglobin sometimes will fall below 7 and so or 6, and they'll become symptomatic and will need to be managed with lifelong transfusions, and are at high risk for iron overload given that they have low hepcidin just by mechanism of the disease, and they are getting transfusions, and so these patients will often need iron chelation therapy to avoid liver damage, because the iron tends to accumulate in the liver, which causes iron overload, liver fibrosis, and can even cause hepatocellular carcinoma if it's not managed properly. So as I mentioned, the pearl here is look at the hematologic parameters, so looking for hemolytic anemia, looking for microcytosis, looking for target cells. These are all manifestations of thalassemia. And definitely look at the hemoglobin A2, since this tends to be increased in patients with beta thalassemia.